Ladies and gentlemen, dear colleagues, I'm Giancarlo Marra from the University of Turin, chief editor of the EU UROONCO platform on prostate cancer. We are here today to discuss a hot topic in prostate cancer, which is actually lymphadenectomy. And we have the pleasure to have with us Professor Declan Murphy from Peter MacCallum Cancer Centre in Melbourne, Dr. Karim Touijer from Memorial Sloan Kettering Cancer Center in NI, and Dr. Giorgio Gandaglia from San Raffaele University in Milan. So again, very hot topic. I will try to make a very quick summary of what is the ongoing situation. So until now, there are no trials that proved that lymph node dissection has benefit in terms of survival, so no trials of lymph node dissection against no lymph node dissection. However, in 2021, two trials published their first results, one from Brazil, one from, notably from Memorial, showing no differences on BCR, although a subgroup of ISUP 325 of a Brazilian trial showed some possible trends and benefits in terms of BCR. And then we jump to last year, where actually at EU, Dr. Touijer presented the results of their trial, more than 1,400 patients recruited, more than half with low to intermediate risk in terms of histology, showing no benefits in terms of BCR, but I think it was a 3% advantage in terms of metastasis at 10 years. Yeah. However, in that case, patients were not recruiting through PSMA PET CT, which we know has, I would say, very good negative predictive value for intermediate risk prostate cancer, around 90%, and a slightly less better negative predictive value for high-risk disease for seeing if nodes are positive or not. Lymphadenectomy is, in the literature, is a quite morbid procedure. More or less in the literature, we can see that every patient that gets diagnosed with a positive nodes, another one gets a complication. So my first question would be to contextualize a bit the presence of PSMA within the results of your trial. And I would like to ask you what is your opinion of the use of PSMA and whether you would still recommend to do a lymph node dissection or not.
Yeah, so thank you for having me. Pleasure to be here and to discuss this very important topic. The trial was conducted before the PSMA was approved in North America or in the US. And so most patients had the standard of the time, which was bone scan, CT scan, whole body MRI, as a pre-surgical staging. The advent of PSMA has revolutionized the staging of prostate cancer, more in the sense that PSMA has a high specificity. In other words, if the PSMA is positive, certainly there is disease. But the PSMA is limited by its sensitivity as a staging procedure, which, depending on the reviews on the meta-analysis, could range from 33% to 45%. And so in patients where the PSMA is negative, I am not comfortable taking that for granted and skipping a lymph node dissection, especially that today we have a trial that shows that the lymph node dissection is associated with a reduction in risk of metastases.
Okay, so your quotes would be, despite a negative PSMA PET, of course, in selected patients, still useful to do a lymph node dissection based on the results of your trial.
Absolutely.
And Professor Murphy, I know in your practice you do, of course, a lot of PSMA, and you're an international recognized expert on PSMA, and you tend not to perform, if I'm correct, lymph node dissection in PSMA negative disease. So can you give us your opinion on the performance of lymph node dissection today?
Yeah, and look, I totally agree with Karim. We clearly showed in the PRO-PSMA trial that PSMA is more accurate than conventional imaging. But we're still limited by the fact that, you know, if you've got a 1 millimeter or 2 millimeter deposit in the lymph node, PSMA PET CT will miss that, and hence the sensitivity, I agree, is 30 to 45-ish% depending on the surgical population. But I suppose the further question on from it is the question that, well, look, even if there was a 1 millimeter deposit of prostate cancer in a lymph node and we didn't see it on a PET scan, so we chose, as we tend to do, not to do a lymph node dissection, it's still not clear that the patient is going to have been disadvantaged from a survival point of view. And I suppose we might choose to disagree a little bit on some of the interpretation of the excellent trial that Karim has led over the past 10 plus years at Memorial. But our practice remains that if the PET scan is negative, certainly for intermediate risk, and even to some, actually, I'll say, even for high risk disease, we tend not to do a pelvic lymph node dissection. And I think it was actually Giorgio's work when they updated the Briganti nomograms in 2023 to incorporate what a negative PSMA PET means for the prediction of positive lymph nodes. It really cemented for us the recommendation for many of our patients that if your PET scan is negative, based on the updated nomogram that Giorgio and company led from Milan, that we think it's reasonable to avoid a pelvic lymph node dissection.
Okay, thank you. And what about in case you have a positive nodes on the PET scan? Are you doing nodal dissection or not?
This is a completely different question, isn't it? And this is where it's so confusing, isn't it? So, and of course, as Karim said, if the PET scan is showing lymph nodes or bone, it's pretty much always right in a good quality center that has good quality PET imaging. So, what do you do with the mesorectal lymph nodes? Because very often what we see on a PET scan is like atypical, just pre-sacral, and do you now then say, well, let's not offer the patient surgery because this is kind of outside template for even extended pelvic lymph node dissection, or the little retroperitoneal thing above the common iliac that you would never see on conventional imaging. And remember, the EAU guidelines now tell us that for CN1, for node positive patients on conventional imaging at least, surgery is no longer recommended. So how do we extrapolate that into the 4 millimeter thing on a PET scan? I think that the role of surgery for PSMA positive nodes, multiple nodes in the pelvis, it has to be limited by the fact there's no data to really support it on one hand. On the other hand, we've been operating on patients like that for years, or Karim's been doing, and others doing lymph node dissections, possibly finding some of those nodes. But even when we find positive nodes, we know that very often the patient it may guide the decision for what next treatment, because they inevitably will need more treatment. So what do we do in summary? I have to say that if we see PSMA positive nodes, depending on location and extent, we're very often offering that patient radiotherapy and intensified hormonal therapy rather than surgery.
I think it's a very, very good point. There is no data to guide us in that so far. In comparison to Stampede, that established a different standard for CN1 disease. But if you look at the trial, which was one of the largest surgical oncology trial that we conducted at Memorial, the highest impact in reducing metastases is in node positive patients. So I think we should not forget that there is a reduction in metastases. And I think we can all agree that in the established natural history of prostate cancer, when patients develop metastases, the impact on survival is going to occur within 4 or 5 years.
Yes, especially now with new drugs. And of course, it's very interesting because there is not a group of patients with positive nodes on PSMA PET CT, but it can be split in who has a tiny single positive nodes in external iliac against someone who has 4 positive nodes, and so we'll have multiple METs, and it's complex, and moreover PSMA is recent, so we don't know actually, there is not a correct answer on whether to do it or not in patients with positive nodes, but I think we will find out quite soon, hopefully, depending on the ongoing studies. Thank you for your answer. And Dr. Gandaglia, I think here we had two examples of someone who's suggesting to perform lymph node dissection, someone who's suggesting, I'm talking again about patient with negative PSMA PETs mainly, not to do it if the scan is negative. And what is your quote on that? On that, of course, you did a lot of work in terms of validating and integrating PSMA PET CT on the prediction of positive node. What is your opinion?
So what we know is that pelvic lymph node dissection is time consuming. It gets with comorbidities or actually morbidity for our patients. and it increases the risk of readmissions. So we want to limit the number of so-called useless lymphadenectomies we do. And the useless lymphadenectomy, based also on the memorial work, is when you remove the nodes and these nodes are negative. So the PSMA PET gives us an instrument to reduce the number of lymphadenectomies we are doing. And how should we use it? We know that it has an extremely high negative predictive value, and this is particularly true when we are talking about patients with intermediate risk disease or favorable high-risk patients. When we talk about a patient with a bulky disease, grade group 5, high PSA levels, in that case, even if you have a negative PSMA PET, the risk of having lymph nodes which are smaller than 3 millimeters maybe, so below the spatial resolution of the PET, is about 20 to 25%. So in that case, I would remove the nodes in the concept of maximizing local pelvic disease control. So this is how we try to interpret the data coming from randomized control trials and all the work we have been doing for years in terms of nodal staging and development of novel models, which have been also validated.
Yes, there are, I think, two main nomograms, which are the Amsterdam-Brisbane Sydney nomogram and then the nomogram you worked on, which has been just recently externally validated. It's actually quite interesting how if you include the data of previous nomograms with a 4+4, 1 positive core is going to get yes lymphadenectomy, and now if you have a negative scan and it's a tiny small core, maybe you are in the percentage that is suggesting not to do lymphadenectomy. So many things going on, many different opinions. I think is a good example of the fact that we are in a hot topic. There are also a lot of trials ongoing. In the Netherlands, there is a PSMA Select who is going to find out a bit the role of PSMA in selecting these patients. We have trials from the Martini Clinic. We have the Ellipse trial from the UK, and I think many others are ongoing. I would like to thank you all for the nice discussion and for being here. And I think we are all looking forward to next results and next steps.
Yeah, absolutely. I just want to make one clarification, if you allow. Time consuming, there's no doubt about it that a pelvic lymph node dissection, we have shown that it adds 45 minutes to an hour to the case. In terms of morbidity, I disagree in the sense that if you look at the papers that were used to produce the guidelines, the EAU guidelines, they quote the paper by Nicola Fossati, your own Nicola Fossati, where he did an analysis, and the morbidity of pelvic lymph node dissection in that paper ranges from 1 to 17%. The guidelines quote the highest number, which is 17%. It turns out that 17% is coming from one single study that has never been published other than in an abstract format. In the randomized trial, in both arms, the morbidity was comparable and was 7%. Morbidity including what is related to lymph node dissection and what is not related to lymph node dissection. But we have to acknowledge that most of the morbidity is going to be the lymphoceles that patients experience, exactly, which on average is probably 3 to 4%. But if you put a lymphocele, which is, if you put it in a decision analysis of utility, a lymphocele is probably a suffering for a week. A metastasis is a game-changing event, is a life-shortening event. And when we talk about predictive models like nomograms, and thank you for updating the nomograms, we always need dynamic nomograms. The nomograms are predicting whether there is positive node or not. They're not predicting metastasis. And the assumption is that if there is a negative node, there is no subsequent metastases. If there is a positive node, that perhaps there is disease progression. Running this trial and running another larger trial of lymph node versus no lymph node dissection, coming up with questions, which what trials should do is bring some answers and a lot of questions, is whether biochemical recurrence is even the appropriate and the adequate endpoint when we are talking about lymphadenectomy biologically for prostate cancer.
May I ask you something, Karim, and take the opportunity, because your trial actually was randomizing patients from limited versus extended, but we do not have data supporting no lymphadenectomy versus extended or even a limited lymphadenectomy. So this is my point when we are discussing about removing or do not consider a lymphadenectomy or recommend against the use of lymphadenectomy. When they cite your trial, the Brazilian one, both trials actually had a kind of a limited lymphadenectomy at least. So how do you interpret and how do you consider it with the fact that now we are trying to recommend not to perform a lymphadenectomy at all, which is not based on evidence at the end of the day?
Actually, one of the lessons learned from our trial of limited versus extended is to embark on another largest trial of lymph node dissection versus no lymph node dissection, which is a very difficult trial to conduct. And we were able to work out all the mechanics of the trial, and we started the trial. We enrolled 700 patients with a good percentage of enrollment of patients. Then we updated with more follow-up the old trial, and we found that there is a statistically significant difference in metastases. And we felt, after talking to our ethical committee, that we lost the equipoise to continue the trial. If the patients ask us, is there any evidence that shows that there is difference in outcome, we have to disclose that, yes, we have evidence that show that there is difference in metastases if we remove more nodes, and therefore we could not continue with that trial.
Okay.
But I am glad to hear that the Martini Clinic, the UK, the Netherlands are asking this question. It takes some trial of limited versus extended to get us actually the courage to ask the other big question of it, which is lymph node versus no lymph node. And I think we are in a better place now than where we were a few years ago looking at just retrospective data.
Yes, I think we are asking us this question very strongly now. There is a lot of ongoing. When I introduced the complication about lymph node dissection, I acknowledge there is a lot of variation. I mentioned 10% because there are two randomized trials which are randomizing patient to lymph node dissection versus peritoneal lymph node dissection plus peritoneal flap. And in both trials, more or less, the complication related to lymph node dissection were 10%. So that is a bit the reference I tend to use. But of course, you had more than 1,400 patients. So the 7% you're citing is approaching the 10%, and it is also varied a lot. Another thing I strongly think about when I'm thinking about those trials is that I agree BCR is not a good endpoint, because in the end, if you have a BCR on an ISUP1 patient, it doesn't lead anywhere. It just leads to testing PSA and PSA and PSA. But if you have a BCR in a high-risk patient, this can be an outcome that could be more of interest, and I hope this trial will soon come out with at least preliminary data on BCR in the high-risk group. So ELIPSE is randomizing, I think, a patient with unfavorable intermediate but mainly high-risk disease, whereas PSMA Select is also including more intermediate risk disease. I think any opinion on what we just discussed?
No, but look, here we are, March 2025, and if we were here in March 2015, we'd be having a similar conversation without a PET scan. March 2035, I'm not sure will we have still answered it. I think we'll have divergent views, divergent data, and it's going to remain, that's my message, one of the contentious topics that we don't fully understand the right answer, despite congrats to Karim for conducting the biggest trial. And I suppose we have to continue to encourage trials. That's why it's very important. And we spoke about this on the podcast, Karim, didn't we? Recruiting 700 patients into the next ambitious trial, and then having to realize we're going to have to turn away from that trial is, personally disappointing. But it shouldn't stop top investigators like yourself and others from continuing to ask the question and for encouraging our patients to participate. It's the only way we'll try and get it. I just think we'll still be here with graying hair in 10 years' time without a very clear, full consensus on the role of pelvic lymph node dissection in prostate cancer.
Great, so thank you very much. Thank you very much for participating. I think it was an interesting discussion, and thank you very much for listening.
Thank you.